All right, it's my pleasure to introduce Michelle Villegas-Gold, who is the Assistant Vice President of ASU Health.
Okay, hello. All right, so I'm going to give a brief overview of ASU Health and then introduce our last speaker, Dr. Norquist. So my name is Michelle Villegas-Gold. I'm the Assistant Vice President of Strategic Initiatives for ASU Health and the lead for our new School of Technology for Public Health. So for those of you who live in Arizona and were born and raised here like me, you know that Arizona is a state that's full of beauty. We have these sprawling, wide open spaces and national treasures like the Grand Canyon and Havasu Falls and Sedona Red Rocks. But when it comes to health, the statistics are a bit ugly. So Arizona ranks in or near the bottom quartile for nearly every metric that matters. Healthcare access and affordability, prevention, public health spending, child economic well-being, mental health, women's health, you name it. So in addition to suffering from diseases like cardiovascular and metabolic disease and cancer and substance use disorders, Arizonans also experience unique vulnerabilities like exposure to extreme heat. And when layered together, these increase our risk of experiencing health-related harms. Now, some of these factors are tied to human behavior, which we all know is learned and deeply complex and can be really, really challenging to change and unlearn. So at ASU, we often talk about our role in promoting lifelong learning, but we don't really talk about the importance of lifelong unlearning, which is also really important. And so how are we helping people and communities unlearn those habits and behaviors that may be reflexive, that have been passed down through generations, but might be more harmful or unhealthy or toxic. But we also know that the onus is not on individuals. We know a lot of this is systemic and structural, and due to things like the ecological and environmental determinants of health, things like exposure to air pollution and pesticides and extreme heat, social determinants of health, which are the conditions in which we are born and grow and live and work and age, but also our health-related social needs. And these are the social and economic needs that enable us to care for not only our health across our lifetimes, but also the health of our families and our communities across generations. These are things like access to safe and affordable housing and air conditioning and healthy foods and broadband and education, stable employment, transportation, and childcare. So what all of this means is that if we want to improve the health of Arizonans, we have a really big job to do. And despite what anyone tells you, and trust me, we have people pitch things to ASU Health all the time, that they've figured it out, they have the answers. There is no silver bullet, there's no simple solution to addressing all of these different interlocking factors. But there are enablers and barriers. So digital health technologies and tools are one of those really important enablers and accelerators, and it will help us do this work. So all day long, we've been hearing these amazing examples of how ASU faculty and staff and students and our clinical partners are leveraging digital health tools and technologies to improve the health of individuals and communities through AI and digital twins and informatics and mHealth and wearables and all of these cool things. But another really important enabler and accelerator is us. It's us as a collective, right? So just by virtue of us being here today, we are tied together by some invisible but really powerful threads. So first, just by being here today, I know that we care. Not we care, but we're committed because it's a Friday afternoon. This is the last session, it's Valentine's Day, and we're all here, right? There's other places that we could be. We all have many priorities to juggle, but we're here right now, and so that says a lot. The other thing that I know is that we're curious. So we're all here because we want to learn more about how digital health tools and technologies are being leveraged to improve health, but we also learn about how we can develop new digital health tools and technologies to shape the future of health. The other thing I know by virtue of us being here today is all of us either work at ASU, we study at ASU, or we partner with ASU. And ASU is a charter-driven university that assumes fundamental responsibility for the health of our communities. And we're also #1 in innovation. And it's the both and there that makes us really special, because there's a lot of universities doing innovative stuff. There's a lot of universities with impressive rankings, but none of those universities are as committed to impact and really improving the health of their communities the way that ASU is. And that's really what ASU Health is. We are focusing our full energy and innovation to be able to improve the health of our communities and create impact at scale. And we're doing this through a cluster of existing and new initiatives that are all powered by AI, by technology, by data science, by engineering. And this includes standing up a new school of medicine and advanced medical engineering. This is one of just 3 medical engineering programs in the entire country, and the first to truly integrate clinical and technological training to create what we call physician years. I think we sometimes are allowed to use that term, right, Jordan? And so that's one thing. We're also standing up a new school of technology for public health. This will have a Master of Public Health degree and a Master of Science in Public Health Technology. These are brand new degrees. They're one-of-a-kind degrees that don't exist anywhere else in the country right now. And they're really meant to prepare people to be able to use technology to improve health at scale. We're also standing up a series of public-facing clinics called ASU Clinics that will really bring innovations and care to our communities, meeting them where they're at. We have a new health observatory led by Dr. Dave Engelthaler, who we brought over from TGen North. And that's really looking at how do we harness and bring together data, different types of data, clinical data, public health data, environmental data, social data, all together to be able to better measure and track, mitigate, and prevent adverse health outcomes from extreme heat events to substance use disorders and overdoses to emerging infectious diseases like avian influenza. So some of you might know that one because it's impacting your ability to buy eggs. I know it's really bumming me out right now. The last thing is, by virtue of us all being here today, though, is that I know we're all collaborative. And collaboration is a cornerstone of ASU Health. And so that includes collaborations with industry partners like Google, our sponsor, and also clinical partners like Honor Health, which is the primary clinical affiliate of our new medical school. And so with that, it's my honor to introduce our distinguished keynote from Honor Health, Dr. Craig Norquist. Dr. Craig Norquist is the Chief Medical Information Officer and Clinical Informatics Fellowship Director at Honor Health. He practiced emergency medicine in the area for 25 years and is focused on trying to improve the system. He is an active runner and cyclist and has participated in the Arizona Ironman triathlon multiple times. In 2013, Dr. Norquist was diagnosed with lymphoma and underwent aggressive chemotherapy in 2021, which strengthened his commitment to enhancing the care delivery system. So.
Thank you very much. All right, so this probably not the best time to try something new, but I've decided to make this a personal address as opposed to trying to reiterate some of the clinical things, some of the digital things that we all learned about. It's such an honor and a pleasure to be able to stand in front of you guys and hopefully bring this home and put some meaning, put some why to why we're doing this. The reason this is new is I've been public with my diagnosis since I was diagnosed, but I've never presented to a group. So you might get that, okay? But anyway, Michelle said so many great things, almost everything that I was gonna say, so I can cut to the chase and get to the good stuff, right? Today's journey has been incredible, right? We learned about all kinds of things. A lot of us are already familiar with this, and I'm jumping too far ahead. My slides, there we go. So we learned about a lot of the stuff that brought us here, right? Precision medicine, how do we use all of the information, all the data, the digital wearable devices, all of these things. How do we put that together so that we collectively can provide better health care to the citizens of Arizona, to our friends, to our neighbors, and to ourselves? What I've learned is I've got a whole bunch of new people that I need to spend a lot more time with, because we all have such common ideas that I think by the end of this, we're going to have created such wonderful partnerships and such wonderful programs that more people are going to come here, and this is going to be phenomenal. So how do we make this promise actually practical? How do we actually get it to practice? How do we get from a common hospital room to what we all maybe are hoping, and this is, I almost promised to not use artificial intelligence, but I had to use ChatGPT to make me the hospital room of the future. I mean, there's some pretty neat stuff going on in there, but how do we get from a room with just a chair and a bed to that? How do we do that when in reality, that's what our rooms look like, right? Some of the nurses, some of the doctors in this room are familiar with this. There are multiple different pumps, multiple different IVs. There's some medicines that can be in the same line as another medicine. They're running at different rates. You might be giving too much fluid, so you have to give a medication to get rid of the fluid. There's so much complexity here and we rely on people to do this day in and day out. And these are some of the things that I think we collectively can work on to remove some of the cognitive burden so that nurse, that doctor can actually be the caregiver and less the technologist that has to run all of those different tools. And at the same time, this is what we're faced with, right? Crowded emergency department waiting rooms. I worked in emergency medicine for years, and I've learned to not walk through the ER with my badge on, because people look at me like, why are you out here when you should be back there taking care of us, right? When as a patient, it's difficult to get into your doctor's office because they don't have any capacity, right? We talk about the digital front door, but the digital front door gets you into a queue, and that can't be what we're going to settle for, right? We need to get beyond that. We need to do better. So we talked a little bit about wearable tech. I am an advocate of wearable tech. I've often thought, why aren't we incorporating this into medicine, right? As a runner, some of us are old enough to remember before we had the GPS watch. We'd have to go and drive the square to get, well, that's 1 mile, and then we'd have a watch, and you'd have to look at it, and then you have to calculate in your head, it's like, I just ran like an 8-minute mile. Yeah, right? And then we went from that to now this, I remember, I actually still have one. I've got this time capsule where I've got all these watches. The Garmin watch, it almost encompassed your entire arm, but it would tell you how fast you're running, and there'd be a little digital guy who's in front of you, and you're trying to catch up to him. And now you've got a watch like this, which has all of this plus more. As Matt mentioned in just a breakout session, these watches now actually will get your pulse ox, your oxygen level, your heart rate, so many different things. If you wear it at night, it will tell you how well you slept, how deep you slept, right? And so we've gone from that to that. But I would say in healthcare, we're still stuck on the Timex watch, right? We have a hesitancy to try to implement new things. And there are right reasons, right? We don't want to take a chance on a patient's life. But more often than not, I think we could probably do a little bit more than we're doing. So, picture of a continuous glucose monitor, right? This was revolutionary for diabetics. No longer do you have to stick your finger every time before you eat a meal or before you give yourself insulin. But now this continuous monitor will measure that throughout the day. And those have even advanced from you had to hold your phone up to it to scan to now it's just continuously feeding that data to you. And when you incorporate this then with the insulin pump, you've basically got yourself a synthetic pancreas, right? And the FDA, there's an interesting story about this. I'm not sure if people are aware. The FDA was never going to touch the ability for a diabetic to associate their CGM with their insulin pump, right? There's too much risk involved with that. They didn't want to take that responsibility. So what happened? The patients themselves actually did it. They formed a group where they actually hacked into both of these, and the output from the CGM went directly to their insulin pump. And they called themselves loopers. And they did this in such a profound way that more and more people did it until thousands and thousands of diabetics had their CGM communicating with their insulin pump, and they no longer had to monitor it because it was not making the kind of mistakes that we in medicine were often afraid that it would make. Well, what would happen if they got too low? What would happen if it didn't give enough insulin? It's like, they're used to that. They were dealing with that, and they didn't want to do that. They didn't want to have to look at one device and prompt into another, so they just connected them themselves, which is awesome. But the other thing that happens, and here's an example of that, is now we've incorporated this into the other uses, right? As somebody who, I wouldn't call myself an athlete, but as a participant in these events, I was excited to watch the Ironman when the two people who won were actually wearing CGMs. And they had incorporated that in their training. So they knew exactly how much to eat, when to eat, how intense they could go, so that they could not crash or have a bonk, we call it, before they got to the finish line. So they were optimizing their own performance, which is like that extreme level, using the tools that were developed for diabetics. And we need to kind of take that line of thinking and apply it to what we're doing clinically more often, right? And then there's this. I actually bought one of these. I haven't put it on yet. This is a sweat sensor that will tell you what your hydration status is. I saw a poster up there. Somebody had a similar version that they're trying out in the desert. But this is for athletes. You wear this, it tells you what your hydration status is, what your electrolyte balance is, or so they claim, and that you should be able to adjust your hydration intake, right? I was at a conference, I think it was 10 years ago, where we're talking about the lack of advancement in medicine, in technology. It wasn't technology specific. And I said, you know, I have a device, I have a smartwatch at the time that will tell me my pace. And then at the time, it could also, on my bicycle, it could tell me how fast I should be able to ride up a hill because I've ridden up that hill multiple times. They were already using technology for something as meaningless as me riding a bicycle, and we weren't doing it in medicine yet. And I often wondered why. And I think we have that potential to get to that place, right? And then as we've also brought up, I'm wearing an Oura ring. And I wear this because I went to a local company which is trying to integrate all this different device. And they showed the integration of your heart rate, your pulse ox, your ice baths, all these different things. And they found that your sleep intensity and your sleep habits were more telling on how you're going to perform than any other metric that they were measuring. And my watch would do that too, but I don't like wearing a watch at night, so I got an Oura ring, and you don't even realize you have it on. That's how how easy this thing is. Obviously, there's a lot here that we have to talk about, and we brought it up in that last session. Not everybody can afford one, not everybody wants to wear one, so how do you bridge those kind of gaps? And hopefully the prices of these will continue to come down where we can then apply it in a much more meaningful way. So a little bit about me. So as I told you, I participate in this thing. I've been a lifelong runner. I've been an athlete, per se. Been a vegetarian since 1988. It was like, oh, how long have you been vegetarian? Because it was kind of trendy, maybe. I thought I was doing all the right things, right? Running marathons, doing these ultra marathons, triathlons, and I had a lump in my arm. And at the same time around this happening was when I was getting into healthcare improvement. And I was listening to people like, as an ER doc, it's like so many people are here who don't need to be here. And at first I joined in, and then I quickly realized when this was me, I need to be there, right? So why am I criticizing somebody else for what seems like a senseless complaint? And that's when a lot of my thinking started to change. And in another breakout session, somebody mentioned we've got students here, we've got doctors, nurses, technologists, but we don't really have patients. And I wanted to challenge that because I'm a patient. And all of us hopefully won't be patients soon, but when you are, we can feel comfortable that we have the right people on your team, right? So the lump on my arm, I decided to have biopsied, and it turned out to be lymphoma. And so I went from having a wristwatch on to having a bracelet on. So I used to get PET scans quite often. I still have to get them regularly, but I always wanted to take a picture of this. This is a radioactive tracer that they inject into your vein, and then you have to sit comfortably and quietly for an hour, and then they measure where that radioactive tracer was taken up. And what you get is from a PET scan are areas that light up. And this is actually my PET scan. And these are my lymph nodes that were quite large at the time and lit up. And I would get these done every 6 months, and I'd see these areas that would light up, and it was almost obvious that things were stable. So I went 8 years with lymphoma without having to undergo treatment. And that was new from about 15 years prior to my diagnosis. When you're diagnosed with cancer, you get chemo. That's always been the motto. And what has transpired since that mentality to when I was diagnosed was, this you don't have to have chemo for right away. This one is a slow-growing cancer. It will be there. We will monitor it. And so I was getting these scans done regularly, and everything was fine. One of the first things I asked my doctor is, can I keep doing these senseless, silly things that I do, like run? And he's like, absolutely. Don't stop doing it. So I continued doing the Arizona Ironman. I used to be able to say that I've done every single Arizona Ironman, but unfortunately my mother-in-law died and I had to miss one. And then COVID, and then chemotherapy, and then I had COVID myself once. So my wife made this awesome kind of shadow box with all my trophies. And then I did what's called the Grand Slam of ultramarathon running, where I did 100-mile runs, 4 of them over the course of 10 weeks, which was awesome. And there were 300 people in the world who had done that. So I was feeling pretty good about myself. Still able to do this despite having lymphoma. So what does any of this have to do with anything? I just wanted to kind of introduce that because that helped me realize I could have been an ER doc. I could have just kept taking care of the patients that I'm seeing and making that impact. But I realized too, I could do more, and there was more that needed to be done because I benefited from being in the family, right? I could call up my friend. I called up, actually, a friend of Dr. Whitfield and mine is the one who did my biopsy, right? Most people would have to wait months to get it. I called up John. I'm like, John, I need to get a biopsy. And he had me in probably within 2 days, and I got the biopsy done. And then I had access to the EMR. Don't tell anybody from InfoSec this. And I looked at that. I refreshed that screen every 5 minutes until the results came up, right? I would get my PET scan, and I wouldn't let anybody know I'm a doctor. They'd say, well, your doctor will get these results in a week, and you might hear back from them in 2 weeks. And I said, well, yeah, that's not going to work. I didn't say that to them. And so what did I do? I walked right over to radiology, and I'm like, hey, I just got my scan. And they opened it up, and I got the scan read immediately. But what happened for me is what I think should happen for everybody, right? The anxiety I felt getting that scan, for somebody to tell me to wait 3 or 4 days and then your doctor will call you when he can, it's like, that's not going to do, right? And so that's what inspired me to start to try to get involved and try to make some changes, try to make a difference and change the system. What else happens when what other kind of things help us change the system? This little guy, right? It's when I was putting this together, I was like, do we really want to go back to that? I mean, it was horrible times. So many people died senselessly. So many people, were isolated. So much changed. But what it did do is it made us change, and it made us in healthcare change rapidly, right? A lot of chaos around. Some of the interesting clinically digital innovative things that we did. In Arizona, we actually formed coalitions and we shared our bed occupancy in our ICUs and our floors because we realized that we were all in the same boat and we had to work together. Otherwise, more people would die senselessly. We worked with the Navajo Nation of when they had patients that needed to come down, where would those patients go? Who's best able to take care of the next patient? And we worked together on, okay, how can we actually make this diagnosis without even having a test for it? Right? We didn't even know at first what was really going on. And so we had to wear all this personal protective equipment that then became increasingly rare. And Ryan's here from our supply chain. And I was just talking to him earlier. He's like, yeah, as a physician, nobody ever taught me anything about supply chain. Stuff just appeared. I needed that. And there it was. It's like, yeah, awesome. But then COVID happened. It's like, I need another mask. It's like, no, we don't have it. And it's like, why, right? So now we were forced to figure out how to be innovative, how to change things on the fly without necessarily having to go through a lot of the steps that at the time seemed meaningless. We were also able to sequence that genome faster than anyone ever thought, right? It was within, 6 weeks or a month that they actually had the entire SARS-CoV-2 genome sequenced. And then they were able to get a vaccine at least out and trialed and then available to patients in a record amount of time. The use of telemedicine. Before, I was in some telemedicine startups, and it was kind of like, okay, this probably is never going to take off. And so telemedicine use before the pandemic in 2019 was at about 16%. In 2021, a year after the pandemic, it was up to about 80%. Organizations around the country were using telemedicine, and that was because it became accepted. If you can't go into the doctor's office, at least you could have a conversation with the doctor and you could actually do it. That forced us to actually then figure out, okay, what's going to be the best platform that's going to help us do this? And we had to do that probably a lot faster than we wanted to, and we made some mistakes, but ultimately we got to the right one, and we got to one that works and works well. Another thing about AI, so one other AI thing, so we were able, or this was at UCSD, they were rapidly able to use artificial intelligence to read chest x-rays to determine if this patient had COVID or not, before we had a test, right? And they had this validated and it worked. And so they were able to get a chest x-ray on a patient, put it into their algorithm, and it would say that looks very much like COVID. And then our radiologists also then were able to do that pretty quickly themselves. It was validated then by each other. And then that was able to be de-implemented, which is something that we don't do often enough, as soon as we had a test available, right? You don't need to apply AI to a chest x-ray if you can get a swab and it comes back in 5 minutes or 15 minutes that's positive. So that was forcing us to apply these tools for something other than something that's just going to be put in a journal. And then at Honor Health, we were one of the first places in the state, if not even the nation, that put one of these COVID patients on ECMO. ECMO is it's a heart-lung bypass machine, for lack of better terms, right? So you take the blood out of somebody, run it through a machine that scrubs the blood and exchanges the CO2 for oxygen and puts it back into the patient. With COVID, people's lungs just get so full, they can't breathe, their SAT levels go down, and so people were dying, right? Our solution to people with low SATs is to put them on a ventilator. More often than not, people on ventilators died. And so we put somebody on ECMO until their COVID infection got better, and they were able to live and they were able to walk out. That person spent about 4 days on ECMO, and that video is still there, and it still is actually kind of moving to watch that. This person who just a week earlier, if he would have been there and nobody thought to use ECMO, probably would have died like so many hundreds, if not thousands of other people. And so somebody was willing to try something, right? And that's what we're all here for. So here's something else then. I'm going to take a little bit of a pivot. And so the other reason we're here is because we care, and we care about ourselves, and we care about other people. And so the ECMO story came out. And my wife and I also have a place up in Flagstaff, and we were driving up to Flagstaff, and we were talking about ECMO because she saw that. And she's like, well, how do you know when somebody should get on ECMO? How do you determine who gets that? Who does it? And there are committees that try to determine that, and they try to use like survivability scores. They try to use all kinds of different criteria. And she's like, well, that's kind of interesting. She wanted to learn more because my wife's kind of a curious person. And then we heard a story about a local runner in Flagstaff. I don't know if you guys are familiar with a guy named Tom Puzzi, or Rivs, they call him, right? He is a physical specimen. People mistake me for him all the time when I take my shirt off. No. He actually was a near Olympic marathon qualifier. He was trying to qualify for the Olympics and he injured himself. That was in March of 2020, so right around this time of COVID happening. But I had kind of followed him because there's a small group of ultra runners in our community, and in Flagstaff, everybody seems to know everybody. Another picture of him, like I said, I mean, people see me running and they call me Ribs. I don't know why, but more importantly, aside, yes, he's got an awesome physique. He's a father of 3, right? And he's just the nicest, most down-to-earth guy. And then we heard that he was actually in the hospital. He actually was at Flagstaff Medical Center, thought he had COVID. His SATs were in the 70s, and this was social media, right? As much as we like to berate social media, I was looking at that. And his SATs are in the 70s, and he wasn't talking about himself. He wasn't talking about COVID. He wasn't talking about the healthcare system being broken. He was trying to raise money for the Navajo Nation so they could have clean water, because they couldn't even wash their hands, and their infection rate was so much higher. Here's a guy, right before he's being intubated with what we thought was COVID, was asking for us to help other people. And I was like, wow, that's awesome. And so my wife was like, well, why can't he get ECMO? And I'm like, well, I don't know, right? It's the easiest answer. I don't know. I'm going to go for a run. And then that didn't sit really well for me. But I don't know him personally, nor do I know his brother. But I follow them on social media, so I reached out to his brother. I'm like, Jake, I'm a doc. Your brother looks like he could probably benefit from ECMO. I don't know what's going on, right? So we're using something that was not intended to be used for medicine to reach out and make that human connection. And you see, like, within a couple hours, he's like, I don't know you, but I know your name, which I was kind of moved. It's like, hey, I'm famous. And gave me a call, and I communicated with them. I communicate back to Honor Health, because I know we have ECMO. They're like, but there's more going on. I'm gonna need you to talk to his palliative care doctor. It's like, oh, crap. And Jacob said to me, I just want him to be alive long enough to say goodbye to his daughters. I was like, well, shit. I gotta get this guy on ECMO now. So reach out to the ECMO team, reach out to that palliative care doc, and she's like, well, he has an aggressive rare form of cancer. And I don't think that, nobody thought he was gonna live. They started raising money for him and raising awareness, selling t-shirts. That's me wearing his t-shirt. Like I said, I get confused for him all the time. And nonetheless, I reached back out to my own oncologist, the oncologist I'm going to for my lymphoma. I say, hey, this guy has got an aggressive form of lymphoma, surprisingly, right? And they're like, yeah, that's fine. We'll take him. He spoke with our ECMO team. Our CV surgeons were like, yeah, we have space. Bring him down. Unfortunately, it took about a day because of thunderstorms and stuff, but they were able to fly him down to Arizona, got him on an ECMO machine. And the other part, I guess, of this whole story is we do these things. We run, we keep ourselves in shape. Obviously, he does sit-ups, not so that you look good in pictures, but he spent a near record amount of time on ECMO. He spent almost 2 months on this heart-lung bypass machine, which is intended to be on somebody for 2 days to 2 weeks at the max. Studies at that time showed that if you're on ECMO for 2 weeks, your survivability at 90 days is essentially 0. They kept him on ECMO for 2 months while giving him aggressive chemotherapy, and he was able to survive and ultimately get off the machine. We were also able, once again, kind of some privilege I had, we're able to get his kids to come in and be able to sit with him at a time when our hospitals were locked down. Good part of the story now, 2 years, so this was all in 2020, and then this is 2022. He got out, he had to relearn how to walk. He ran a 2:12 marathon in the winter of 2020. He ran 9 hours and 30 minutes for the New York City Marathon. He's got a slice of pizza, he's high-fiving everybody. He didn't care about times anymore, he cared about giving back to the community. And he's just, like I said, he is the nicest person. He doesn't recognize me because of all the fog he was in until now. We've met multiple times afterwards. And now just more recently, this was just last week. This is a friend of mine who's also a nurse, Isaac. He met him and shook his hand. And so now this guy now is almost 5 years out from an aggressive rare form of cancer, which itself had a 40% 5-year survival, was on ECMO for long, right? So these are those chances that we can take if we're just willing to try to do something a little bit further. And then also willing to try to help people get into a system that sometimes seems so frustrating, so opaque, right? His wife actually wrote an incredible book called Everything All at Once. Unfortunately, it's the same time that movie Everything, Anything All at Once came out, so people got it confused. It's a really, really good read. She weaves in and out her own personal history with then what it was like for her to have to go through her husband being in a hospital on ECMO for that long. And I made the book, she kind of noted me, and I felt like I was a bit player, right? I was a role, I helped connect them to somebody. But in the book, she wrote that I was the first person that gave them hope. Everybody else told them that his cancer is not survivable, that his oxygen level is too low, despite his physical fitness, they were writing him off. And I just gave them hope. And that, to me, once again, made me think there's more that we can and should do, right? So that's why we're here. But then back to me, because it's all about me, right? kept getting my scans. I was feeling good about myself. I helped somebody, right? The book wasn't out yet, but I was feeling like we were starting to make a difference. I was working with Dr. Whitfill. We did incredible things with our COVID teams. We made changes. We were doing really good things. And then I started to not feel so good, right? I was still getting my scans. One scan in June of 21 was fine. Carry on, everything's great. But then within about a month, I was like, I just can't. I mean, I'm not going to brag, but I couldn't work out as hard as I did or could. And then I started to have pain. I was like, well, maybe it's just the way I'm standing. Maybe I tried to do too much. And then after about a week and a half, I couldn't sleep because I had to stand like this. I was sleeping on all fours, and my wife's like, you think maybe you should go get checked yet? I was like, yeah, okay. So unfortunately, then my lymphoma had transformed to a much more aggressive form. So within a month, I went from normal to having a mass that was different. So then I became another patient. And I also took advantage of some of the benefit in that I got a room when I was getting my chemotherapy. There I am, I call myself Yoda here because I got an infusion of immunotherapy that made me have what's called rigors, where I started shaking. And as a doc, it's like, oh, rigors, here, give them give them Demerol. It's one of the only reasons you'll still use Demerol, but I'm like, just give them some Demerol and a blanket, everything will be fine. And it's happening to me now, and it's like, ooh, this is something, I'm in a ride. My wife was terrified. They kind of knew who I was, so suddenly I feel like I got every single blanket in the hospital put on me because they were concerned. And it's like, and then it went away that quickly. So, yeah. And there I am, and this picture still, they talk about association. So this is a medicine called adriamycin. At first, all these medicines are going into you, and you're like, oh, they all kind of suck, but none of them are really bad. And then the nurse happened to tell me, oh, this is the one they call the red devil. I'm like, oh, you probably shouldn't have told me that. She's like, yeah, everybody hates this. And then from that point on, every time, now I even see it, I get anxious. Because it's a horrible medicine. But there I am getting my chemo. My wife gave me this little smiley beanie, just going through it. But the other thing is I just didn't want to give up. Right? I didn't want to stop doing the things that I thought were my identity, so I kept trying to work out. And that's another Ribs shirt. When he was recovering, he had a saying that was like, less candy ass, more badass. And they sold that shirt for a moment, and I was like, oh, I have to have that. And so I bought that. And the thing I learned is, activity while in chemotherapy, activity while ill is not unadvisable as long as you're doing it within reason, right? Talk to your doc about doing it. And what I realized was the more I tried to keep doing things, the better I felt and the better I was able to get to my next round of chemotherapy. And then I pushed that to the limit, of course, and I climbed Humphreys Mountain with my wife. That was 10 days after a round of chemo, so I was at my lowest blood counts. And that was kind of emotional. The month before we tried, and I had to stop. Anybody done Humphreys? It's up at Flagstaff. The saddle there, I got there, and I had to turn around, and I felt miserable until the next month. And yeah, I had to drag my wife up the last part. She really didn't want to do it. And then my friends got me a cake. Sorry, I had to block out some of the letters. So then I finished chemo, and yeah, so that was it. But what I did realize, like I said, I had the privilege of being in the family. I was a doc in a medical community in the same one that I practice in, so I got a lot of benefits and a lot of treatment. But what I did here too was also equally moving. It was equally troubling. We heard patients actually haggling with their employer to take more time off so they can get another round of chemotherapy. We heard people trying to plead with their insurance company to approve an anti-nausea medication because they knew they were going to get sick. I didn't experience a lot of that stuff because, I'm a big deal. No, I'm part of the system. But hearing it from other people was like, yeah, this can't stand. We can't do this anymore. And it actually did happen to me once. I had all my pre-medications. They pre-treat you so that you don't get sick when they're giving you the Red Devil and all this other stuff. And then like a half hour goes by, I'm like, how come I'm not getting the first infusion? Like, oh, we're waiting for prior auth. It's like, oh, that's that horrible word primary doctors talk about. I'm an ER doc. We don't prior auth anything. We just order it and it happens. And I was like, well, that's kind of dumb because I'm on like my 4th round of chemotherapy. Why does this have to be authorized? Because it's a standard treatment. But yeah, it did. And then Dr. Radhakrishnan, who was here, I called her and she's like, she got it taken care of. And suddenly the medication appeared. But I had that ability to do that, and many other people who are getting chemotherapy with me weren't able to. So a lot of these reasons, right, just continue to inspire you and motivate you to make the system better. Thanks for that. Not that I was able to fix it, but I'm going to continue to try to do it. Every day we wake up, we try to do what's better for us. And this is the potential that we have, right? Just remember, what we do matters. You might not notice it. You might get so in the kind of routine of taking care of patients, of doing your research, of doing something that for you, this is just what you do every day. But for that patient, that's the worst day of their life, right? Or they don't know what's going on, and you can actually take the time and spend that time with them and make them feel better. And the other thing that I realized we didn't do, and I never did, is you never celebrate your victories. You obsess over your failures, and you think that that's what's going to make you a better doctor, or a better person, or a better athlete, or whatever. But you always have to step back and remember the things that you're doing and the impact that they have. And reaching out to a family made me feel like this is what we need to do more of. And I think we can do a lot better. We can make better devices to do that as well. I did all that stuff, or we did that collectively, communicating by Instagram Messenger or whatever that thing is called. I slid into his DMs, I think the kids would say. Imagine if we had the tools where Flagstaff Medical Center knew that we had ECMO and it just was like, there's a bed available, why wouldn't you apply? And just make those transfers super easy, right? But sometimes we also have to shield the caregivers from some of the ideas that people have, right? These tools that we develop, they don't work perfectly at first, and sometimes they actually get in the way and you lose trust in it. I like to joke that some of our earliest predictive algorithms that we try to employ using our EMR were for, well, who's most likely to die in the hospital? And one of the criteria they used for that was, is there a palliative care consult or a hospice consult? It's like, well, yeah, that's gonna, right? But they were bragging that their predictive algorithm was like 90% effective. It's like, because we don't order those kind of consults on people who aren't gonna die. And so it wasn't ready, and it got in the way, and it eroded the trust. And so part of my role and Dr. Whitfield's role is to help protect our providers from some of these seemingly senseless things. And I guess the other part of that is somebody thought that was a good idea, and it probably is a good idea, but they just weren't applying it right, weren't applying the right workflows, right? And that's where I think this sense of collaboration, these developments that we'll soon be making together are going to really make a really big and important impact. And we could do this together, right? A lot of the work that you guys are doing are, work with patients who have Alzheimer's, work with patients who are getting older, who are lonely, who are whatever. We have a lot of those patients. You guys have a lot of researchers who want to work with them. Seems like a perfect marriage, right? We should be able to do that, and I think we really can, and I'm looking forward to working with that. And then we also have to remember that the tech needs to be intuitive. I get side-eyed at a lot of these conferences with a lot of the informaticists, where it's like, the EMR has to be as intuitive as a cell phone. And you're like, oh my God, all the doctors say that. It's like, well, why haven't we done it yet, right? They would rather argue that medicine is complicated, but so is a cell phone, right? Some of us, we remember having a phone that was wired and it didn't even work then, and then we went to the wireless phone, and then a cell phone was this big brick that only, really important people and drug dealers had, right? Now it's like, now my phone actually does so many other things, and they got there, and they didn't say, well, phones are complicated, but that's what we continue to say about the EMR, about medicine, and I think we can get there. And I have a minute left. Real quick, and I'm bragging, I didn't even talk about AI and ChatGPT, but that's just going to turbocharge all of this. Some rules to live by that I learned a long time ago from an ER mentor. Always do what's best for the patient as rule number one. Rule number two is then do what's best for those people caring for the patient. And then rule number three is don't confuse rule number two with rule number one. Because in our line of work, facing physicians, they're the most important person, but we sometimes forget that the patient is actually there, and we need to make sure that they're accounted for. Last couple of things, right? I did this, I typed it in wrong. I'm like, oh, that's Collins, right? It's like, no, that was Voltaire. That was like centuries ago, Voltaire said, don't let perfect be the enemy of the good. And I'm guilty of that. I think a lot of us are. It's like, I can't put this out there. It's just not good enough. Not good enough is better than what's there if a system's broken. But then take it to the next step. Take the Jim Collins. Like, don't let good be the enemy of great. Don't settle for what you put out as a minimum viable product. Continue to iterate on it, make it better, make it intuitive, and make it work. And I think the collaboration that ASU and Honor Health will be able to do that probably better than anyone else. And I'm so looking forward to doing that. And the reason is that we need to make healthcare great. Not for somebody else, but probably because it's going to be us who are going to need it. So, thank you very much.
Thank you so much for that inspiring talk, Dr. Norquist. I think we have time for a couple questions if anybody would like to ask. Dr. Norquist, any questions?
I'm an open book. Sure, yes, sir.
Go back.
Yeah. No, I hope everybody heard the question. I'll try to paraphrase, but are there ways we can try to fail forward more in medicine instead of backward? And plus a whole lot more that was probably much more diligently and specifically said. And I like to think in medicine, we exaggerate a lot. Everything in medicine is life and death. Right? It's like, oh, you can't do that because a patient's at stake. It's like there are certain areas that I think we can firewall from that trial and error process, right? The OR is one of those places where a lot of things you're not going to muck with, but there's also a lot of places where you probably should muck with and you need to. Emergency medicine, likewise, right? When somebody comes in a cardiac arrest, you're not going to suggest, hey, let's think about pumping here instead of there or what, right? But there are a lot of other things that happen in that same space. And so I guess to your question, I would say, yes, there are, but it takes that kind of that trust and that collaboration and knowing where those areas are that are untouchable, that are truly untouchable. And just because somebody tells you no once, maybe that doesn't mean no for everything. And so, yeah, absolutely. I mean, there are so many things in, like in surgery where they say, oh, we can't do that because a patient's life's at stake. It's like, I'm just suggesting you do a pre-op checklist and you all call each other by the first name. It's like, that's not life or death, right? We're asking it 5 seconds so that you know each other's names so that when something happens, you can call the right person. But we like to just throw everything in there. Well, we can't because it's a life or death situation. So yeah, I think there is a lot more that we could and should be doing. And I think by understanding what those processes are is how you get to that. And that's where the field that I'm in clinical informatics and Dr. Whitfield and Dr. Colson, that's what we learn, right? Where in that continuum of care delivery should technology be and where would it potentially not work well for those reasons? And so I would say, let's partner together, informatics and research, and make sure that we're doing this the right way. Yeah.
Yes. Thank you so much for the talk. I hear you spoke so much about efforts in research and academia and healthcare, honor, health of the world. What do you think the role of private industry, startups of the world should be? What could they do to help in this journey?
Yeah. No, she just asked, we talked about research, we talked about care delivery, we talked about research at ASU, but what can private industry and startups do? And I was talking to Dr. Whitfield about this. It's like all this stuff that we're talking about here today is awesome, but and my wife also told me, don't talk about politics, but I have to. But we're in a climate where we don't know what's going to happen tomorrow or the next day. Where's our funding going to come from? Are we going to have funding? How are we going to do any of this stuff? And so we have to rely on private industry. But a lot of those silly interventions or silly, maybe well-intended projects that we implement come from those same areas, because I think their incentive or their motivation is maybe different than ours, right? Our primary incentive is to take care of that patient and then take care of the people taking care of the patient, right? That would be, I guess that was another thing I wanted to talk about, but short of time. The burnout crisis is something that we have to deal with, and we can't continue to add more to the plate of people. And sometimes the private industry looks at it as like, well, if they just did all these 5 things first, then I could have an algorithm that would tell them to do something different. It's like they can't do 5 more things. And so we need to really work with industry to make sure that they're working with us to give us the tools we need that will help us, as opposed to looking at the healthcare economics and seeing dollar signs and thinking I need a part of that. But we have to think outside the box. Yeah.